Welcome to Grand Rounds, April 2026. So today we have Dr. Christiana Vandegrift, and my apologies, we just have to fix this, talking to us about negative pressure wound therapy updates for the neurologic population. Dr. Vandegrift is a neurologic physical therapy resident at St. Luke's University Health Network in Bethlehem, Pennsylvania. She earned her doctorate of physical therapy from DeSales University and joined St. Luke's Neurologic Outpatient Rehab Center shortly afterwards, working with patients post-stroke, traumatic brain injuries, concussions, vertigo, and chronic neurological diseases, including Parkinson's disease, multiple sclerosis, and Huntington's disease. She also works with patients experiencing limb loss before and after receiving their prosthesis. Her interest in wound care, specifically the use of negative pressure wound care, began as a student in her acute care rotation in residency, where she spent 2 to 3 days each week applying wound vacs for patients with pressure injuries and post-surgical incisions. Since then, she's had opportunities to observe in outpatient wound care offices and continue learning about wound care practices. In the future, she plans on becoming a board-certified specialist in neurologic physical therapy and in wound management. So this is the statement of need, and the target audience is all providers. This is our designation statement, and the planners and presenters have nothing to disclose, except the one comment that Dr. Vandegrift will share momentarily.
So thanks everybody who is joining either live or virtually, or will be listening to this recording later. My other disclosure statement is that there are images of wounds that are included in this presentation. So I am assuming that if you are listening, you have an interest in wound care or are interested in wound care and that you are okay with seeing pictures of wounds. They aren't terribly gruesome, but I do just want to prepare you for the slides ahead. So here are our goals for the presentation. After completion of this course, participants will be able to identify the risk factors of wound development in those with neurologic conditions, be able to explain the principles, the parameters, and the correct application of negative pressure wound therapy. You'll be able to compare the outcomes of using negative pressure wound therapy to other commonly used management techniques for wound care. And finally, discuss the possible benefits, complications, and risks of using negative pressure wound therapy in the neurologic population. So let's first talk about the integumentary risks for those with neurologic conditions. A lot of our patients in the neurologic population often experience some sort of deficit in their healing factors, meaning that not only are they at an increased risk for developing a wound, but when a wound does develop, there is a reason why that wound might not heal quickly or correctly, or it might lead to further complications down the line. Some of those reasons might be a comorbidity that they are presenting with. A lot of our neurologic patients have a pretty extensive past medical history. One of the most common comorbidities that we see in the neurologic population is type 2 diabetes. We know that those who have type 2 diabetes often have poor wound healing due to their blood glucose levels, poor circulation, and poor sensation levels. In the similar fashion, our neurologic patients often have impaired circulation, again, whether that is from the neurologic condition that they are presenting with themselves, a comorbidity that they have, or just from decreased mobility levels. So our neurologic patients typically are not as active or mobile, and so their circulation is going to be impacted. We know that if there is a lack of arterial circulation, especially to the extremities, that means that blood and nutrients and oxygen are not getting to any wounds that are in their extremities to help with the healing process. If there, on the contrary, if there is blood that is pooling in the extremities from a venous standpoint, that blood pooling could also lead to a venous ulcer. Our neurologic patients also are at an increased risk for falls, and anybody who works with a neurologic patient population can attest to this. Our populations include those with Parkinson's disease, post-stroke, spinal cord injury, traumatic brain injuries, neuropathies, and other debility or decreased mobility deficits. So our patients who experience a fall might result in an actual traumatic wound itself from the fall, or it could be considered a non-traumatic wound. For example, if they fall and they are down on the floor for a long period of time, they could experience some skin or soft tissue breakdown. Or again, if they are at an increased risk for falls, they're probably not moving around as much as they should be, and that could lead to a risk of pressure injuries, which we will get into a little bit later. Our neurologic patients also tend to have a history of surgical procedures. So again, that increased their risk for infection from surgical procedures that they've had in the past. And that might also decrease their mobility levels while they are recovering from surgery. So I want to talk more about pressure injuries because these are one of the most common wounds that we see in our neurologic population. So a pressure injury is that localized damage to the skin or soft tissue, typically over a bony prominence of the body, or it could come from having a medical device or a brace that's donned for a long period of time. That intense pressure in that one specific area is prolonged and could be in combination with a shearing force. So for example, if a patient is using a transfer board to go from edge of bed to wheelchair or from wheelchair to the commode, and they are sliding across that transfer board, of course, that is the incorrect way of using a transfer board and could increase that shearing force, especially to their ischial tuberosities, which we don't want. That's why we always want our patients to bump across a transfer board. A pressure injury could be intact or it could be an open ulcer. And of course, depending on their sensation levels, it may or may not be painful. So we don't want our patients to ever be in pain. However, if they aren't experiencing pain with a wound, it could mean that they don't know that one is developing and they don't know if one is progressing or not. Pressure injuries are also affected by a patient's nutrition level, the condition of their skin or their tissue, the perfusion levels to that soft tissue, what's considered the microclimate, so an area of the body that might be warm or moist is more susceptible to a wound developing there. And again, those other comorbidities that we talked about earlier. Pressure injuries are classified as stages 1 through 4 and unstageable. So we will go through those and quickly review the differences between those stages because negative pressure wound therapy is not indicated for all pressure injuries. So the risk of developing a pressure injury, especially in our neurologic population, really boils down to two main reasons. Their decreased mobility levels, which means that they're in a sedentary position for a long period of time. That might mean that they're bedbound, or even if they are modified independent using a wheelchair, they still are at an increased risk for pressure injuries, especially at those ischial tuberosities, sacrums, because of that prolonged seated position. If they are bedbound or require assistance to transfer or reposition, then they're not moving around as much as they would be able to if they could reposition or transfer themselves. So if they are requiring the assistance of another person to do that, they're just not doing it as often. And again, they're at an increased risk for falls when they're ambulating, so they're not going to be moving around as much to avoid having a fall. A lot of our neurologic patients also have some sort of decreased sensation. It could be unilateral or bilateral, depending on their condition. And of course, if it's a spinal cord injury, it's going to depend on what level of injury they have. It could be impaired or it could be completely absent. And again, if they don't feel that wound forming, then that wound might progress pretty quickly. So let's review quickly the different stages of pressure injuries. We have stage 1, which is your non-blanchable redness of intact skin. This does not include any maroon or purple discoloration. That is another type of pressure injury that we'll go into later. But they may be preceded by changes in either sensation at that area, temperature of the skin, and also firmness or just the feel of the skin and soft tissue of that area. And it might start off as blanchable redness. So that's why it's always very important to make note if there is blanchable redness at a certain area of the body, because if it's not treated correctly, it could lead to a stage 1. Stage 2 are your partial thickness skin loss with exposed dermis. So these might be an open wound bed that is usually red or pink in color, or it could be a blister that is either intact or ruptured. Even if it is an open ulcer, there will not be deeper tissues that are visible, so you won't see any adipose tissue or bone or cartilage. There's no slough or eschar that is present. Slough is light tan or yellow in color, and eschar is usually darker in color, like a dark brown or a black. Our stage 2 pressure injuries typically result from a poor microclimate, so again, a moist or warm area of the body, or those shearing forces, especially during transfers and repositioning in bed. Stage 3 is your full thickness skin loss. So for these pressure injuries, adipose tissue will be visible, but you won't have any deeper tissues that are visible. So your bones, your tendons, ligaments, all of your connective tissue will not be visible. It's just your adipose tissue. Epily, which is the rolling of the wound bed edges. Let's see where that laser is. Perfect. So we can have here in this picture, you can see that there's rolling of the wound bed edges into the wound. You can see that occur as, in combination with either tunneling or undermining. So those are extensions of the wound bed, exactly what they sound like tunneling or little extensions farther down into the deeper tissues. They may be present along with slough and eschar as well. And then our stage 4 is the full thickness skin and tissue loss. For your stage 4 pressure injuries, you're going to see, or at least be able to palpate those deeper tissues. So your bone, tendons, connective tissues. Again, that epily, the undermining and tunneling are usually present along with your slough and eschar. So it's important to note that negative pressure wound therapy is indicated for stage 3 and stage 4 pressure injuries. It is not indicated for stage 1 or stage 2. But to round it all out, we have our unstageable pressure injuries, which these are typically a stage 3 or stage 4, but they are unable to be staged at that moment because of the sheer amount of slough or eschar tissue that is covering the wound bed. And then we have the deep tissue pressure injuries. Those are similar to the stage 1, but they are more of a dark red, maroon, or purple in color. They could be intact or non-intact. Sometimes they present as a blood-filled blister in that area. They result from prolonged intense pressure, usually at an area of the bone and muscle interface, and they are often preceded by changes in pain and temperature as well. So similar to your stage 1, but a little bit different. So we'll switch gears now to negative pressure wound therapy. I think anybody who works in wound care can attest to the fact that wound care is like arts and crafts. And I think negative pressure wound therapy is a great example of that because the application of it can be very complex. But negative pressure wound therapy is the application of a subatmospheric pressure to a specialized foam or sponge dressing that is placed within a wound bed and then is connected via a suction pad to a vacuum device that has the vacuum pressure and a collection canister for your wound drainage. So I have an illustration here of a very simple wound, negative pressure wound therapy device. So we have the wound bed here, and then we have the black sponge or black foam dressing. There are different types of foams that are used. Black foam is the most common. There is a white foam that is actually more dense So the white foam, if it's more dense, it is less likely to break off into pieces when it is removed. So your white foam is typically used in some of those tighter areas, especially the tunneling, because when it's removed from that tunnel, it's less likely to break off. But then your black sponge is used for a lot of the less complex types of wound beds. We have our suction pad that goes on top here, and then it is sealed with a clear film drape that creates your airtight seal. The suction pad is connected to tubing, which is then connected to the device. Here it shows 120 millimeters of mercury pressure. Most research shows 120 to 125 as your standard parameters. However, I did see as low as 110, just depending on the complexity of the wound. And then on the side of these devices, you'll have a canister. They're typically clear. That's where the wound drainage from the tubing is collected. It's clear so that you can see what type of drainage it is and you can describe it in your notes, as well as has measurements on the canister so that you can measure the amount of drainage. So like I said, negative pressure wound therapy is very similar to an arts and crafts project. And unfortunately, it can be very time consuming because of how complex some of these wounds can be. But the first step of this is that you want to cut a piece of that foam to fit the entire wound bed. You're going to fill any of that tunneling or undermining or any extensions of that wound bed with the sponge. And again, you might be using different types of sponge depending on the type of tunneling that you're seeing. If there are any exposed areas of bone or cartilage or ligaments or connective tissue that you want to protect from being directly in contact with the sponge, there are a lot of different protective films that you can place over top. But the most important part is that you want foam touching as much of that wound bed as possible. You want that piece of foam or the pieces of foam to mirror the exact size and the exact shape of that wound bed. That is one of the most important pieces of information because the more foam that is touching the wound bed, the better the suction is going to be applied and the better healing you'll see within that wound bed. That being said, you don't want any foam to be touching the area around the wound or any intact skin. That's because that foam is going to be filled with the drainage from the wound bed, and you don't want any of that drainage sitting on top of intact skin. That could cause maceration to happen. It could lead to infection. It could lead to another wound itself. So you want the foam to mirror the exact size and shape of the wound bed so that it's filling the wound bed, but it's not touching anywhere outside of it. Once you get your foam piece to be that exact shape and size, you'll secure it with that semi-occlusive dressing film, also known as drape, that will give you your airtight seal. And then you'll place the suction pad, which is a circular pad that's connected to that tubing, connected to the canister, and that will be placed on top of the foam. It has to be in contact with the foam to work, whether that means it is in contact with the actual foam in the wound bed, or there might be some instances where you actually want to bridge from the wound bed to another area of the body using pieces of foam, and we'll get into where that might be applicable in a little bit. So here we have a wonderful illustration, and because it's an illustration, it's perfectly done. But we have our wound bed here, and you can see that every aspect of that wound bed is touching the black foam sponge. So that means that we're going to get the best benefit from the vacuum suction since every area of that wound bed is being touched by the sponge. We then have our suction pad that's on top, and that's connected to our tubing that is then connected to the vacuum. The other great part about this picture is that it starts to talk about some of those mechanisms of action from negative pressure wound therapy, including macro deformation, which are the visible changes that we see to a wound. So it gets smaller and it gets more shallow. They also talk about taking out the drainage from that wound. So again, it's coming through that sponge using that negative pressure, coming through the suction pad and then down the tubing. So we don't want extra drainage to be sitting in the wound that could delay healing and lead to infection. However, it does retain some moisture for that wound bed because wounds do heal best when there is some moisture there. All right, so now we start getting into some of the actual pictures of wounds. So here we have a small wound on a lower extremity. You can see that we have black foam or black sponge that is filling the wound bed here. We have our clear drape, and it looks like it's providing a nice airtight seal. A lot of the devices will have an alarm that goes off if the seal is not strong enough for the suction to happen, so you'll know. Or you'll also hear it. You'll hear like a whistling sound or an air sound if there is a leak in that seal. The suction pad here is the circular piece. For this one, it fits just perfectly on the size of the wound. Now, if this wound was a little bit more narrow and the suction pad was kind of hanging off the sides, all that would need to happen is another piece of foam that is circular, that is just a little bit larger than the suction pad itself, could be placed in between. Again, the suction pad just needs to be on foam that is connected to the wound bed, and foam works with foam. So if you can just put another piece of foam right underneath the suction pad so that you don't have edges of it hanging off, that could affect your airtight seal as well. And this also does show really good placement of the tubing. It's not kinked or it's not bent over itself, so that won't affect the suction either. We have another example here of a pressure injury that was on the medial malleoli. Again, the suction pad fits, it's big enough that it's going to fit, the suction pad will fit on the wound bed itself, so we don't have to worry about adding another piece underneath that suction pad. This patient most likely had compromised skin around that area, so there's a protective barrier there. There's a lot of drape used, but again, you want to have an airtight seal. So when it comes to some of these bonier areas of the body, sometimes it requires a lot of drape to get that seal. But if we look over here, there's actually two tubes. This one tube, the bigger tube, is for the vacuum suction. And then the second tube here is for installation of fluids. So sometimes negative pressure wound therapy is used in conjunction with installation of fluids to the wound bed. This could be just normal saline just to help keep the wound bed moist, or it could be an antibiotic solution if there's an infection of the wound bed. So that fluid gets introduced via the suction pad and it gets introduced to the wound bed and then is taken back out. And here is an example of the bridging technique for wounds. So this is often done if the wound itself is in a pretty high area of pressure, no matter what the position of the patient is. One of the best examples of this is if it's an ischial tuberosity. So if a patient is lying or sitting in bed, most often that area is still going to be an increased spot of pressure. And placing the suction pad right on top of the wound might actually increase pressure there, as well as think about where that tubing is coming out of. If that tubing is underneath the patient, that could cause a pressure injury to happen in itself. So this might be an instance where you bridge from the wound bed to another area of the body. For an ischial tuberosity, typically we bridge to the lateral hip or thigh area. And again, foam works with foam. So as long as that foam is connected to another piece of foam from the wound bed and you place the suction pad right on top here, that suction pad will work just as well as if it were placed right on top of the wound. The only caveat is that you have to make sure that you're protecting that intact skin underneath the bridge. So you'll have that clear drape dressing as a protective barrier. You'll have your sponge or your foam that goes right on top to create that bridge. And then you'll have to place another piece of drape on top for that airtight seal. So this just prevents having that suction pad underneath the patient. It makes it more accessible, especially for the tubing placement as well. So we have our mechanisms of action for negative pressure wound therapy, and these can be broken up into primary or secondary. Primary includes that macro deformation, which are the visible changes that you see in a wound bed. It gets smaller in size, and it also gets more shallow as it gets filled with more granulation tissue. You have your micro deformation, which are those microscopic changes, especially to the wound bed. Different colors indicate different types of tissue that are coming into that wound bed. You have the removal of that drainage. Again, we don't want a lot of drainage sitting in the wound bed. And then that just optimizes the environment for healing. The secondary mechanisms of action are changes that we don't necessarily see to the naked eye, but we know are happening. So it's controlling a lot of the inflammatory markers that get sent to the wound bed for healing. We want inflammation to happen, but only to an extent. So it's going to control those factors. It's going to promote the growth of blood vessels in that area, angiogenesis. That's going to increase blood flow to the area to maximize healing. It's going to promote the differentiation of cells, so not just the growth, but the division and the differentiation of different cell types. It's going to help with the formation of granulation tissue. So that's that red or pink tissue that we see in a wound bed. Again, it means that there's more blood flow to the area. And it might also stimulate some of the peripheral nerves in that area, which is especially important for our neurologic patients who have developed a pressure injury from decreased sensation in that area. It's at least going to try to protect some of those nerves that are in that area of the wound. All right, so this is probably the more gruesome of the pictures. We have a diabetic foot ulcer. I liked this because, again, a lot of our patients have type 2 diabetes and often present with ulcers on their lower extremities and specifically their feet, especially if they have decreased sensation or completely absent sensation. So the picture on the left-hand side is before any negative pressure wound therapy was applied. The wound bed itself is pretty dark in color, suggesting some slough or eschar tissue. There is some bone that is exposed right there. And then the area of the big toe is pretty deep. So if we go to the second picture, this is after one application of negative pressure wound therapy. So already we're starting to see more pink and red tissue. So that's that granulation tissue that's starting to form, increased blood flow to the area. There is still some bone that is exposed, but it looks to be smaller than what's exposed in the first picture, suggesting that that granulation tissue is starting to form over the bone and start to close that exposed area up. And if we look at the big toe, they have a couple stitches up here, which suggests that that wound bed was able to close enough that they could finish the closure with stitches. They definitely would not be able to do that when it still looked like this. And then here we have after the, it was 4 applications of negative pressure wound therapy, they were able to get the wound bed shallow enough that they could finish it with a skin graft. Now, what we've been talking about is considered the more traditional style of negative pressure wound therapy. There are other types. One is a single-use negative pressure wound therapy device. These are especially useful for patient use if they're being discharged home with them or if they're going to be out in the community with them, specifically because they're canisterless, or they can be. So for patients, it's not always great for their wound drainage to be on full display for everybody to see. So these don't have a canister with them. The drainage is into the device and is not able to be seen. And they're often smaller in size, so they're easier for a patient to manage. There is also the negative pressure wound therapy option with installation of those fluids that we saw in one of the pictures of the ankles. Again, that's introduction and then evacuation of intended fluids for wound healing factors. Again, it could just be saline to help keep it moist, or it could be antibiotic for infection control. All right, so we're going to apply this now in the clinical setting. So our clinical recommendations for negative pressure wound therapy include stage 3 and stage 4 pressure injuries, which we talked about a little bit earlier, especially if the patient has some exceptional circumstances for their wound healing to begin with. So if they've had complications after other wound care interventions like infections or need for revision or wound opening, wound dehiscence, then it might be beneficial to try negative pressure wound therapy for their wounds. If their caregiver abilities are limited, especially if they require frequent dressing changes with a more standard type of dressing, a negative pressure wound therapy might be an option to try. And if they have some of those other comorbidities that already place them at a risk for impaired wound healing itself. It has been deemed a safe and effective treatment, even for chronic stage 3 and stage 4 pressure injuries. And there's more research that's coming out to suggest that single-use negative pressure wound therapy may be more effective, especially for some of your surgical wounds. And again, if it's in an outpatient or a home setting. In a study from Vandegrift and colleagues, they looked at complications of wound healing after amputations in patients with peripheral arterial disease. So these patients already had a compromised wound healing from that comorbidity. They had an amputation done, and they looked at negative pressure wound therapy with installation versus a standard dressing, which was a gauze dressing. Now, it's a very small study. There were 50 people in the study. But it does show that those who had negative pressure wound therapy, there were less patients who had a formation of a hematoma or seroma after their amputation, less patients who had wound dehiscence, which is the reopening of a wound, and less infections at that surgical site compared to the standard dressing. There were also no patients with negative pressure wound therapy who required a revision amputation after the initial surgery. So again, while this is a small study and there's definitely more research needed with larger sample sizes, this suggests that negative pressure wound therapy is a great intervention, especially for those who already have impaired wound healing factors, just to help with their quality of life after a surgery or a wound develops, and also to help decrease the financial burden on the healthcare system. Specifically in our neurologic population, one of the common ways of dealing with a pressure injury is using a reconstruction surgery, and negative pressure wound therapy is often used to help with that reconstruction surgery to help prevent the infection and, again, wound dehiscence or reopening of those wounds. These are the two most common complications with pressure injury healing. And so negative pressure wound therapy helps decrease the risks of those happening. They can use the irrigation of fluids with negative pressure wound therapy in those chronic stage 3 and stage 4 pressure injuries. That will help increase the amount of granulation tissue that forms and remove a lot of that wound drainage, and will also stimulate those nerves in that area. With the use of negative pressure wound therapy, that also allows our neurologic patients to actively participate in rehabilitation. Now, yes, you do have to manage the device and the canister and the tubing. However, it's no different than if a patient is hooked up to an IV line or if they have any other lines, tubes, or drains from other surgeries or other complications. So it does still allow for our patients to start their rehab process, which is important after a neurological event. And that might be limited depending on other dressings that could be used. Possible risks and complications of negative pressure wound therapy are possible. It's not perfect. For example, patients might experience increased pain levels, especially if their sensation is intact. This usually happens during dressing changes, especially when those pieces of foam are being removed. The dressing and the suction pad could be poorly placed. The materials used could unfortunately be contaminated or infected. That's a risk all around the board. However, one of the most common complications is when foam is left inside of the wound bed during a change of the dressing. This is why it's pretty standard practice that when negative pressure wound therapy is applied to the wound bed, on the drape, it is notated how many pieces of foam were put in the wound bed and what color, so that when the next person comes in to remove that foam and change the dressing, they know exactly how many pieces of foam they should be looking for and removing and what type of foam. So that helps avoid having any pieces of foam being left inside of the wound bed. And then, of course, that tubing could also result in pressure injuries depending on the placement, if it's left underneath the patient's body for a long period of time, or if there's any devices that are placing it against the patient's body. So I have two case studies of patients who I worked with in the acute care setting who had negative pressure wound therapy applied. So our first example was a 52-year-old male. He was status post a spinal cord injury. That happened about 5 years ago. He was actually admitted to the hospital after having a fall at home. He was on the floor for about 5 hours before his wife came home and found him. His personal medical history included type 2 diabetes, hypertension, and hyperlipidemia. He was modified independent at wheelchair level. However, he did admit that he was no longer going to outpatient PT. He wasn't as active as he was prior, and he wasn't using any pressure relief strategies at home anymore. So he had unfortunately developed bilateral ischial tuberosity pressure injuries. One was a stage 3 and one was a stage 4. There was bone that was exposed in stage 4, so we had to be really careful of that. And there was a pretty good amount of the slough and exudate present in both wounds. So we opted to use negative pressure wound therapy for both of those injuries, partially due to the comorbidities affecting his wound healing already, and also due to the severity of those pressure injuries. Again, it is indicated to use for stage 3 and stage 4, which was this patient's case. This is the perfect example of using that foam bridge to bring the suction pad to his lateral hip or thigh areas on both sides, instead of having it sit directly on the ischial tuberosity to avoid any extra pressure being placed in that area. And that also helped avoid having any of the tubes running underneath his buttocks or his legs while he was in bed. He ended up being discharged home with a traditional negative pressure wound therapy unit. This was mainly because he was still going to receive home nursing for other medical complications, and so the nursing staff would be able to take care of the dressing changes for a traditional home unit. The second patient that I have included in this presentation is a 68-year-old female. She was status post a right MCA stroke about 1 week prior to us seeing her. She did have a stroke about 3 years ago, but didn't have any deficits residual from that stroke. She also had diabetes type 2 and bilateral knee-OA. She lived alone, but had 2 children that lived locally that checked in on her. She used a single point cane for longer distances, but was pretty active. She unfortunately developed a stage 3 pressure injury on her left lateral malleolus, and that unfortunately did get infected. This was from poor bed positioning and lack of a turning schedule while she was in the hospital. So we opted to use negative pressure wound therapy with the installation of an antibiotic solution to help with that infection of the wound bed. She did require 2 people for all ambulation at first because we needed 1 person to guard her and then a second person to manage the device and the tubing. But we were eventually able to progress her to carrying the unit herself while she was walking, and then only needed 1 person to guard. So another great example of how using negative pressure wound therapy still allows our neurologic patients to start participating in their rehab. She was eventually discharged to a traditional gauze dressing while she was in acute rehab about 2.5 weeks later after we saw her. So to summarize everything up in this presentation, there's definitely more research that is needed for negative pressure wound therapy, specifically on the prevalence of it in the outpatient clinics. A lot of our neurologic patients end up going to multidisciplinary neurologic rehab centers for their PT, OT, and speech therapies. And the addition of wound therapy and wound management in these outpatient clinics could allow for a more collaborative care plan for these patients, because often if they are discharged home with home nursing for their wound care, they aren't eligible to start their outpatient services right away. So there is definitely a need to see the application of negative pressure wound therapy in an outpatient setting and how we can incorporate that in a multidisciplinary fashion. Further research is needed on the efficiency of applying negative pressure wound therapy. As I said, it can be very time consuming. And for that patient that had 2 wounds that we treated, we were with him for at least 2.5 hours. So the efficiency in the applications of the application in both inpatient and outpatient settings, especially for patients who are then going to be using it at home or in the community. And then there's further research always needed on how those materials can be advanced for better wound healing and prevention of infection or other complications. So in summary, patients who have neurologic conditions are at that increased risk for development and wound progression due to their mobility and healing deficits. Negative pressure wound therapy is safe and effective and promotes healing factors that decrease the healing time of wounds when applied correctly. The effective wound healing interventions are essential for patients with neurologic conditions to help them avoid any further complications, as well as start their rehab process as soon as possible. But there is further research that is warranted for the use of negative pressure wound therapy in different settings, especially in outpatient, and in conjunction with other modalities for wound healing. So I have my references here. I also have my information here, and I'd like to open it up for any questions.
And we only have one resident presenting today, so we have extra time for questions. So please feel free to either unmute yourself or type in your questions into the chat.
Okay. Christy, how do you feel like in the outpatient setting where you've been that you feel like there are patients that could have utilized this while you were treating them, whether they're amputees or maybe a different diagnosis?
Definitely more with amputees in particular, because the wound healing process for that can be much longer than if somebody has a pressure injury, depending on the complexity of that injury. So I definitely see a need for it in the outpatient clinic, again, because those patients can start with outpatient therapies, even if they're waiting, for example, for an amputee, if they're waiting for their prosthesis. They could still come in and start with bed level exercises and start with the education piece that's needed to start their rehab. But if they are at home with home nursing for their wound care, that's going to prevent them from coming in. So I definitely do see a need for it. With pressure injuries, depending on the severity of the pressure injury, they might not be eligible to really start rehab right away. But I do think that it would be an important component for our multidisciplinary rehab centers to at least start looking into.
How much does a wound vac cost and the equipment to go with it?
So they can be expensive. I'm trying to think of what they were at the hospital. They could be a couple $100s. And also depending on the cost of the supplies, how much of the supplies it is a cost that patients would need to either pay for out of pocket, or if their insurance does cover it, that's great. But then also the cost that it would cost the clinics to house those materials. So definitely something to look into, but the devices themselves can be a couple $100s.
Okay. And what do you bill as a physical therapist when you're doing wound care?
So there was an acute care, there was a specific billing code for wound management and wound interventions. And then we would also bill for any, because depending on where the wound is, you are still also performing bed mobility and transfers. So sometimes you could also, depending if that was appropriate, you could bill for bed mobility and therapeutic activity, but there was a specific billing code for wound management, and at least in the inpatient setting.
You mentioned earlier that, and by the way, great talk. Thank you.
Oh, thank you.
You mentioned earlier that generally it's not used for stage 1 and 2. Is that more because it's not necessary, or is it because it's not effective?
So the research said that it was not as effective. And so with your stage 1 isn't going to be an open ulcer. Your stage 2 could be an open wound bed. However, they're typically not as deep. So if it's not needed or not applicable, it's likely not going to be as effective. And they're probably going to try a more standard wound dressing, like a gauze or a bandage dressing.
Okay. All right, awesome.
Yeah.
And you also mentioned about the microdeformation. Is there any macrodeformation that occurs with negative pressure wound therapy?
Macrodeformation, yeah. So that brings the wound, it makes the wound smaller and it makes it more shallow because it's filling in with tissue. Are you talking about a
So no, I'm just making sure I understand.
Yeah.
It's the secondary effects, the mechanisms, secondary mechanisms are all about microdeformation and not macro deformation.
So the macro deformation is just the visible changes that you're seeing. So you're able to see that the wound size is getting smaller, and that's because of those secondary mechanisms that are coming into play.
Gotcha.
Mm-hmm.
Oh, thank you.
Of course.
What other questions do you guys have?
Steve, are you able to see the chat? Because
I'm looking.
Okay.
Yes. Okay. Well, if you do have any further questions, please feel free to reach out to Dr. Vandegrift.
Mm-hmm.
And thank you very much for attending. And make sure that you take both the quiz and the course evaluation. And we look forward to seeing you next month. Thank you very much.
Thank you, everyone.